tell me a little bit more about your approach to using SBRT as metastasis-directed therapy in a newly diagnosed metastatic patient.
Yeah, so I mean, like I think that's the space. So if we're thinking de novo metastatic disease, and we're thinking lower volume, so I'm not a big fan if you get to many metastases, 4 or 5. I know my radiation oncologists can go above that, and they can zap even more than that. But I think when you see that many lesions, I'm going to lean more towards just systemic therapy, and maybe consider radiation to the prostate. But I think when you get into those patients where you're thinking, and this is just based off of experience on this statement, but I think when you see somebody who has like one metastasis, particularly like one pelvic bone metastasis, for example, that's the ones where I'll really think about, okay, maybe I can do metastasis-directed therapy, especially if I find it on a PSMA PET. Like, can I do metastasis-directed therapy, radiate the prostate? And the reason why I think it's so important to think about that is that what I'm really thinking is, can I give an ultimately finite duration of the hormone therapy to this gentleman and not do this indefinitely, and kind of thinking like 2 years or so. And if I do metastasis-directed therapy in those scenarios, I feel more confident about stopping. So that's where I think I use it more often than not. But I think when we're thinking de novo versus metacrinus, there's a big divide in the amount of data you have to support using metastasis-directed therapy. Like most of the studies where we reference STOMP, ORIOL, EXTEND, the vast majority of these were in patients who had metacrinus, basically biochemical recurrent prostate cancer, where there were less data to support what to do in the de novo setting.
And Vadim, I'm curious if you have genetic testing, germline, somatic, does that impact, do your findings impact your choice of treatments for the patient?
Well, in the hormone-sensitive setting, to some extent, right? You can. There are certain findings on genomic testing, like SPOT mutations, that potentially are indicative of more favorable disease course, right? So maybe you would be, less likely to. I don't know if I would say less likely to treatment intensify that patient, but maybe like not use triplet therapy, for instance. Whereas, of course, in patients with BRCA mutations, for instance, then, it wouldn't really probably change your therapy in the hormone-sensitive setting quite yet, but you're kind of worried about that patient potentially having a worse disease course and, needing additional therapy later. And of course, we have trials coming up that may change, the approach in the hormone-sensitive setting as well. So those are kind of some of the major things I lean on, I would say.
Could I layer on a couple other prognostic tools? Because I think we always talk about volume, and then like there's this desire to go towards genomics. But there's other things, and we've talked about this before, other clues that maybe you're dealing with a more aggressive biology that may benefit from upfront chemo, and that might be more important than volume. Like you see someone who has 6 metastases, 6 isn't too scary, but then if your PSA is 2 in that scenario and your Gleason score was 5, your grade group was 5, that's going to shift the way I'm going to think about the tumor entirely. And then I think another one, in addition to the ones, I agree with everything Vadim said, and in addition to those, I think you could add in when you find early loss of multiple tumor suppressors, especially in the, and not just one tumor suppressor, but like if you have 2 of 3 of, let's say, AVPC molecular signature with RB1, P10, TP53, layered onto those other variables, now you're getting a little more nervous. And
you see all of those usually in the very beginning when they're just metastatic hormone sensitive. That's something that develops after they've been on an ARPI for a while, usually. Right?
Yeah, I found them sometimes in my experience, but they are less common.
I think the one thing that was clear from the NCCN guidelines is that we should be doing somatic and germline testing in all patients that come in with metastatic hormone-sensitive prostate cancer.
What about pain? Does that influence how you approach a patient? Someone maybe who has a couple mets but has a lot of bone pain, are they a different?
That's a patient that comes in symptomatic from their disease is somebody I'm more likely to intensify early on. Alicia Morgans has done wonderful work in this regard. Some post hoc analysis of prior clinical trial data suggesting that, hey, maybe patient symptoms can help us understand who needs to be intensified with chemotherapy. My approach is very similar to everything that's been stated here. Somebody comes in with a lot of disease. They come in highly symptomatic. If you see some weird things like a discordance between their PSA and their volume of disease, those are the types of factors that lead me to favor early chemotherapy. I am very interested in, how the genomics can influence our decision making early on. I don't think we're quite there yet. I love having the germline testing early, because we hope that these patients will spend years and years in the hormone-sensitive disease space, and it can still be important to family members in that time. So if you find a patient with a BRCA2 alteration and you do cascade testing in a family member, that can impact their cancer screening.
What did you think of the Decipher presentation at ESMO, moving into sort of the metastatic space and
determining who could
docetaxel?
respond or not respond to chemotherapy with
Right.
docetaxel? I thought that was pretty interesting, actually. We don't use it there. We use it on patients who have pretty much biochemical recurrence to decide more or less if we're going to treat somebody for 6 months versus 2 years. That's where we use it very often at Cornell anyway, the Decipher. I don't know that there's not enough data on that either, and nobody knows if you should be 6 months, 2 years, depending if they're cribriform, Gleason 5. There's many things that drive what you do. We use Decipher there. I've never used it to decide whether or not somebody would respond to chemotherapy. That was an interesting presentation, though.
Yeah, and I think they'll be looking to validate in some prospective studies, but interesting that a signature developed on a localized prostate cancer remained somehow prognostic in the metastatic setting, but only seemed to differentiate benefit from docetaxel and not from abiraterone, which was interesting, and across high and low volume, which is one of our best sort of clinical predictors.
Isn't that interesting? You know, the ARPI is high volume, low volume, it doesn't matter. Metachronous, synchronous, it doesn't matter. And now Decipher high, Decipher low. ARPIs pretty much show benefit across the spectrum. So when I'm seeing somebody with hormone-sensitive prostate cancer, my starting point is ADT and ARPI, right? And then we can go from there.